To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or you can sign up for the email list to be notified of upcoming webinars. We're continuing to update our schedules, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content is made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly and indirectly from any use of the video content, which is provided as is and without warranties. We are looking for an athletic trainer to join our team. This is a full-time clinic-based position. Working in a sports medicine clinic, BMO certification is preferred. Please feel free to pass our information along if you know of a qualified candidate. More information regarding applying can be found on our website. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website. Dr. Kristin Terry is our speaker this evening, and she is a primary care sports medicine physician at the University of South Florida. She completed her family medicine residency and primary care sports medicine fellowship at USF as well. She has a current leadership position as the Morsani College of Medicine Faculty Council member. She is the head team physician for several sports at USF, including USF Volleyball and USF Track and Field. She also works with other universities in the Tampa Bay region, including being a team physician for St. Leo University. She will be speaking today on concussion, from the field to the office and then back. And what a timely presentation, certainly, with the most recent SCAT, SCOAT, and all the good concussion information that has come out. So up next, we are going to have, so she will get a little pop-up coming up here. Perfect, we can see your slides. I can actually, we can see your screen too. Oh, perfect, yeah. You have slideshow mode.
All right, can you guys hear me okay?
Yes, we can, hooray.
All right, I need to remember how to, there we go, present the slideshow. Okay. Okay, let's go to the beginning. Okay. All right, so you can hear me okay, Michelle?
Yes.
Okay, all right, so we'll get started. My name is Kristin Terry, and yeah, I'm talking about concussion today. Trying to make it pertinent to you guys. So from the field, and then a little bit about what I do in the office, and then hopefully back to the field. And yeah, I'm a primary care sports medicine physician at the University of South Florida. Okay. So goals and objectives. All right, I missed my conflict of interest. There we go. So I don't have any relevant financial disclosures or any disclosures. I'm not going to discuss any particular products or anything like that. Of note, though, I do work for University of South Florida, and they do pay my salary, but I'm not advertising for them or anything, so really no relevant disclosures. Okay, so goals and objectives. Really just a general understanding of the definition, the diagnosis, and initial treatment of sport-related concussion. I'm definitely going to spend some time and hit the changes from SCAT5 to SCAT6, discuss the physician role, as well as a little bit into more complex treatment strategies for prolonged sport-related concussion, just so you can have a general understanding of what your athletes are going to go through. We're going to hit on return to play guidelines, and then discuss a little bit about retirement from sport due to concussion. All right, so definition. So this is the newest definition of concussion from the consensus statement on concussion in sport that was released in October 2022, so relatively new. I'll go ahead and read it. Sport-related concussion is a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in an implosive force being transmitted to the brain that occurs in sports and exercise-related activities. This initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow changes, and inflammation affecting the brain. Symptoms and signs may present immediately or evolve over minutes or hours, and commonly resolve within days, but may be prolonged. So I will say, the definition keeps changing as we learn more. Year by year, there's so much research in concussion, but it's one of those areas in medicine that we really don't, there's so much to learn. We really don't know a whole lot about. I really want to, push that this really should be the kind of confusing area in sports medicine for us. When we deal with musculoskeletal injuries, they all kind of make sense. We know where everything attaches. We know what makes things work. Biomechanics makes sense, but the brain really is a whole different beast. There's so much we don't know and how it works. We can't really image it and see what's going on with it like we can musculoskeletal issues. So, I'm constantly studying and reading, and I consider myself pretty good at what I do with concussions, but I still get cases that really perplex me, and I have to go back and read more, and sometimes there's nothing in the literature even. So I really encourage you to keep your level of discomfort. So if you're ever, in this area and feeling super comfortable, then it's really time to kind of check and make sure you're not missing something, because it can get dangerous if we feel too comfortable about this topic. Okay, so this is just kind of a figure. So I pulled it from the AMSSM position statement on concussion from sport from 2019. I really just wanted to show, just kind of reiterate the complexity of symptoms of concussion and how interrelated they really are to each other. In medicine, we always like to categorize things in our brain to make it make sense, and we like to compartmentalize everything. But in concussion, we really can't just focus on one system in the brain. We have to keep in mind that everything's kind of interconnected. It's super complex, and we just have to keep in mind when we're diagnosing, treating, and really clearing athletes back to sport. All right, so first topic is moving from the SCAT5 to the SCAT6. So SCAT5 is out. We really want to start using SCAT6 if we haven't yet. This is probably the most applicable area of the talk to you guys. So I'll go over each change. I scan through it pretty thoroughly and try to put down all the changes so that way you can be familiar with them. All right, so the first thing that they changed from SCAT5 to SCAT6 is they added this little workflow section, our flowchart section. The red box, the red flag box was already there on the SCAT5, but not the flowchart. So it can be pretty helpful on what to do in more worrisome situations and when to send to the ED or ER. So if there's a red flag symptom, get them out of there. Usually go to the usually needs to go to the ER. And then if there's no red flag symptoms, kind of go down those, yellow flags, I guess I'd call them, categories, and then kind of make your decision from there. So it's a little bit of a helpful tool. It's not super specific, but it can be pretty helpful. All right, so the next thing, there were a couple items added to the observable signs section. So one would be falling unprotected to the surface. So if you get hit and they kind of fall, not protecting themselves, that's a sign. An impact seizure, and a really high risk mechanism of injury. Go back one. Okay. So the next one would be the cervical spine assessment. It's changed now, and I like the change that they added. So there should be palpation of the neck prior to checking range of motion. That's pretty huge. If there's bony tenderness, do not move the neck. So they added this on there, and I definitely like that. I feel like that's definitely necessary. And then they changed up the neurological screening stuff. So the new SCAT6 includes coordination, ocular motor screening in the initial steps, so on the first or second page, while the old SCAT5 only had it during the exam. So this will kind of help you, if they have those signs, symptoms, kind of determine and be sure that they need to be out of the game for sure. So the SCAT6 also adds the question of whether the examiner notes whether extraocular eye movements are normal when the patient's looking up and down from side to side. So if you see abnormalities in the area, if there's just, we know how the eyes move, and if they're not moving like that, then be on the safe side and pull them out. And then the reading portion was taken off the off of the SCAT5, and the tandem gait assessment on the SCAT6 is more detailed than what you see in the SCAT5 above, and we'll talk about that in a little bit. Okay, so now moving on to changes off the field assessment. So they took some of the questions off the background, one of them being dominant hand. I think that is a good call because I never asked that either. Some of the other questions I kind of wish they would have left on there, because number of concussions, the most recent, and the recovery time are pretty important. But I think the reason they took that off is that those are things that we talk about when we're going through treatment and stuff like that. And I think they tried to shorten a little bit of it so that way it's more of a sideline assessment rather than like this long drawn out office visit. All right, and then for the memory testing, they took off the 5-word option, and now there's only 10-word options. So they did this so that way they took away basically the ceiling effect. So if you have a pretty intelligent athlete and you're asking them to memorize 5 words, some of them can get by, even if they are concussed, with memorizing the 5 words, and it's kind of a false negative. So the 10-word is pretty hard for almost anybody. So hopefully you'll have a baseline for the athletes and then see if they're close to their baseline. And then for the months in reverse order, they actually added a time measurement. So instead of slowly thinking about it and going backwards with the months, the athletes encouraged to go quicker. And it kind of gives us a little bit better data point. If it took them 10 seconds during their their baseline, and then it took them 2 minutes during their SCAT, then it's probably a sign that they are not their normal state. Almost done with this. I hope you guys can see this okay. It doesn't look too bad. So the SCAT6 has a much more detailed coordination and balance exam. The modified BEST is still consistent, but it adds options for foam pad for challenge. It also gives 3 trials of the tandem walk and instructions on how to do it. This adds a lot more numerical measures to the exam, so we have more data to track. It also adds the optional dual gait test where you count down by 7s too. It's kind of challenging, even if you're not concussed. And then it gives you a practice run 3 trials, which they count down from starting numbers. So this is kind of nice. If the really big thing is that you guys know your athletes. So if if you've got a gymnast and they have amazing balance to begin with, you might want to give them a little bit more challenging task on a foam pad. So that way you're able to assess them a little bit better. And then of note, there's also a pediatric SCAT6, but I left this one off because we kind of have a lot of things to cover. So, but keep in mind that there's also a pediatric version that's had some changes too. All right, I'm going to skip questions and just do questions at the end because of how many people are on here. All right, so care until seen a physician. So this is in the meantime until they can get in. Let's assume that they have no physician instruction or they went to ER, but this is up to you guys. So this is super important. The main take-home point is strict rest is really old school. We're getting very far away from that. So the benefits of, there was a paper, it was entitled Benefits of Strict Rest After Acute Concussion, a randomized controlled trial. It was a pretty good study and it showed that strict rest actually results in prolonged symptoms. So you'll get a lot of physicians that aren't, very they don't keep up with the concussion data and they will advise strict rest. Yeah, I would have encouraged to go get SCAT. It can result in prolonged symptoms basically. So if the kid looks good, they definitely don't need strict rest. However, there was other studies that showed that screen time limitation in the first 48 hours showed significant improvement. After that, it didn't really matter that much. So the first 2 days after the concussion, you don't even have to completely eliminate it, but restricting it will help out with their symptoms. And then even getting into more recovery, aerobic exercise should be started at a light, tolerable intensity as soon as symptoms are stabilized. So it might be good to wait 48 hours after injury, but there are other cases where they started quicker if they felt pretty well. And the patient can still be symptomatic. They just need to have pretty stable, maybe more milder symptoms. And you definitely want to get them moving at least some before 10 days. That helps with outcomes quite a bit more. And then back to school. So, on the flip side of strict rest, being against strict rest, returning to more intense cognitive activity too soon actually showed worse outcomes. So I always tell people you really just need to meet a happy medium. So you need to push yourself and do things, but as soon as those symptoms really start to build up, then you got to back off. So I tell my athletes, this is the time to learn how to listen to your body. If it feels bad, your brain is saying don't do it. And some kids are really good with it and some not so much, but overall, returning to school is pretty important. So sometimes they don't get into a position for 2 or more weeks, and holding them out of school that whole time when they're starting to feel better is super inappropriate. If a physician clearance is far away, the student can return to school when they feel able. I always tell them if their symptoms worsen, they need to stop, rest, maybe go to the nurse's office, maybe even go home. And I always tell them just have an escape route home in case they're not feeling well throughout the day, because school can definitely provoke symptoms. And so if you're in the position to advocate for the student, please do. Sometimes parents and teachers are super lenient with this student and then they get super behind and then they cause more stress there. And then, others are super old school where they're hammering them to go back too soon and the kid's not feeling well at all. It's making it worse. So, and they could bomb a test or anything along those lines. So just really advocate for your student, I would encourage. A 2023 study more recently published in BJSM showed that 93% of student athletes returned to school fully without accommodations within 10 days. So 10 days, keeping them out of school 2 weeks straight is usually completely inappropriate. But I've seen it done many times. And a lot of times it's even done by a physician. They see their primary care physician or they see an ER doctor who, like I said, isn't necessarily up to date. and they say, oh yeah, be out of school for 2 weeks. And that's pretty significant for a high school kid. They can get super behind. It can really affect their grade, and even if they're a senior, their career in the future. So, kind of be careful about that, and really just know that the data says that if they're feeling well, then going back is a good thing. Also, treating the neck early shows a lot of good evidence. So if there's cervical spine stiffness, pain, and of course there's no red flag symptoms like you're worried about fracture or something along those lines, and you're comfortable knowing that, then get the neck moving and maybe do a little bit of earlier treatment on the neck. It's shown pretty good outcomes of earlier return to play. All right. So the physician role. So, I am a primary care sports medicine trained physician, so maybe I have a little bit of bias towards us. But, really our whole thing in primary care sports is to get the athlete back as soon as possible, but as safe as possible. And most of us are pretty good at it. So just a little bit about what a primary care sports medicine doctor is. A large majority of us completed family medicine residencies. Some of us did internal medicine or PM&R, ER, peds, but either way, we usually have done a residency that treats the whole body, and then we do a fellowship in sports medicine where we do sport-related injuries. So concussions involved in that, musculoskeletal stuff, cardiac stuff, a bunch of other things. But it's important to know that we do general medicine as well. So we treat the whole patient brains as well, and not just orthopedics. So we all get different training, but we should be pretty competent and safe, efficient return to play for athletes. All right. So I'm pulling up this complex figure again, just to emphasize the complexity in the concussion diagnosis. So after sideline assessment, if they screen positive, they should be sent to a physician for a definitive diagnosis. All concussions should see a physician. There is no imaging and there's no blood tests for concussion at this point. It's all based on history and exam. So the primary diagnosis of concussion is a lot symptom-based. So it can be kind of convoluted and difficult in our young athletes because it could just be them being an adolescent or college kid. If the kid went through a breakup or they're burnt out, they can have a lot of concussion symptoms that mimic it. So, keep that in mind. And, the other important thing for athletic trainers taking care of teams is that you guys know your athletes. If the athlete gets sent to me, I usually don't know them. And I usually have no idea of who they are, what they were like before the concussion. So the more information you can give us, the better. When I was training, I saw a kid and he was really slow. He talked super slow. His cognitive function was super low. I had no baseline, and I held him for a long time, and he was not getting better until finally I talked to his athletic trainer, and she said, "Oh yeah, he's always like that." And so he was back to his normal baseline. That's just how he was. I just didn't know because I didn't know him. So that can be super helpful for us instead of kind of shooting in the dark with them. So what your athlete can expect in a concussion initial visit, we do history exam. We do usually pretty intensive exam. A lot of us do cognitive testing. So any of those neurocognitive testing that you guys are probably familiar with that I'm not going to mention. School accommodations, I'll usually do general instructions and maybe even medications depending on symptoms. So sending the SCAT results to a physician can be really beneficial to see where they started at, where they're at now. There was a SCOAT, I don't know how you say it, SCOAT6 recently created for an in-office evaluation by a physician. If you're curious, you can check it out. It's pretty close to exactly what I do in office, but keep in mind that every physician practices differently. And then also a lot of physicians are on time limits. So if you look at that assessment tool, it's pretty intensive. It's gonna take at least 30 minutes, I would say at least. And a lot of physician time slots are 10 to 15 minutes. So the physician may not do even close to all of that stuff. So don't send them to a physician and assume that all of this is going to be done and have that comfort, because it may not be there. All right, so when do I initiate treatment? Right off the bat when I see them, especially with the new information that the neck and vestibular symptoms, if treated early, are beneficial. So usually I'll start with that and get them moving a little bit. Hopefully at least they'll be working on the neck with their athletic trainer if that's an issue, and maybe even vestibular symptoms if the athletic trainer is comfortable with that. We'll talk about that a little bit later. Usually initially I'll just give them home exercise to work on, tell them what to do and what not to do, because physical therapy can be pretty expensive and it can pull them out of school, and I really overall don't want to do that. I might prescribe them some stronger anti-inflammatories or even a migraine medication to help with their symptoms. Then I'll also discuss active recovery with them and maybe give them an exercise prescription, which we'll discuss in a bit. Persisting symptoms are greater than 4 weeks. So typically after 4 weeks, if they're still struggling, that's when I initiate a lot more intensive treatment. We'll discuss that further too. All right, exercise prescription for concussion. There's really 2 ways you can go about this, and this is really good for you guys to know. One is if you don't have, any exercise testing available, really all you need is something to monitor their heart rate and something to kind of monitor how hard they're working, like a treadmill or, something along those lines. But the top one's easier and a lot quicker if you don't have the time or the resources. The other being more accurate, give you more data points. So with the, if the formal exercise testing is available, you advance exercise based on symptom level. So basically don't exacerbate or don't worsen the symptoms higher than a mild level or more than 2 points on that should say 1 to 10 point symptom scale. So if they're starting off at a 3 and you get them moving a little bit, and then after a while they go up to a 4 or 5, then okay, it's time to stop and basically do the same thing each day, and then you kind of move on. Just make sure they stop when they hit that threshold there. Formal exercise testing, you can get their heart rate threshold. Basically, you do the same thing. You find their max heart rate that doesn't exacerbate symptoms higher than a mild level or more than 2 points on a 1 to 10 point symptom scale. So same thing, you exercise them, and then as soon as they reach that point to where they're, if they start at a 3 and now are a 2 and then now they're 4 to 5, then it's like, okay, look at their heart rate and then push them to a little bit under that heart rate each day. And then you can retest it every few days to every week. And that's their exercise prescription. That's the active recovery that's recommended. And there's really no limitation on the amount of time to exercise, the more the better. Of course, if it's like pathological and they're exercising like 5 hours a day, that's too much, but there's no limitation. It's not like, oh, only do 20 minutes. No, as long as they're feeling okay, they can keep going, as long as the symptoms are stable. Okay, we're not, once again, not going to stop for questions. All right, so a little bit more on prolonged symptoms. Let's see how I'm doing on time. I'm not doing too bad. Okay. So with prolonged symptoms, it's considered greater than 4 weeks in the literature. And at that time, I start to focus more on either what the most primary problem is, what they're really struggling with, or what I feel like the main underlying symptom is. And then if we can treat that and get it better, a lot of times many other things fall into place. All right, so first, let's talk a little bit about why this happens and what it actually means. And it is pretty common, and I see it in the concussion center quite a bit. So yes, there are definitely plenty of cases of prolonged symptoms of concussion. That is the #1 question I get. Everybody wants me to put down a time frame of how long these symptoms are going to last and how long until they can get back to sport. And I always tell people concussions are completely unpredictable. Usually if it's a really heavy impact like a motor vehicle collision, which is not what we're talking about today, if there's loss of conscious, amnesia, brain bleed, which once again we're not talking about today, or multiple injuries, symptoms can go on for months. With athletic concussions in particular, usually, the time frame I use is 2 to 6 weeks is rather standard. And that 4 weeks is technically considered prolonged, so I start to treat a little bit more intensely at that point. Everybody also wants to give videos on how it happened and how hard it was. And to be honest with you, it makes me no difference because I have seen, like I had somebody fall off a building and had a giant brain bleed, and he was so much better in like a month. And then I've had this tiny little injury where a lady got hit in the head with a little sign and she was out for months. So it's really, it depends on so much. It's so complex that even with the impact, you can't really give much of a time frame for them. So why happens, I was watching a lecture before this with a concussion expert named Dr. Letty, and I really like this quote from him. He said, if you follow me, it's kind of complex. The metabolic cascade is over within hours to days after the injury. So by the time the prolonged symptoms are occurring, the metabolic crisis, abnormal autonomic dysfunction, abnormal cerebral blood flow is all over. So you have to get it out of their mind that they're still concussed. What you have with persistent symptoms is an associated injury that happened at the time of the concussion, but it's a different pathophysiology than the concussion itself. So I'm glad he said that because I have so many athletes that are, a month out and they're like so freaked out because their brain is injured and they have a concussion, and it kind of freaks them out emotionally and psychologically as well. But if you can get it out of their heads that, hey, your brain is okay. You had an injury. We're working on the symptoms. And don't worry about your brain being, keep being re-injured every time your symptoms get worse. I always tell them that all the time, like, it's okay. And then, yeah, you do get prolonged concussion symptoms, but there's also complicating symptoms that have no relation to the brain injury at all and lie outside of the concussion. So, a lot of times I'll get kids sent to me that's, they think it's prolonged concussion symptoms, and it's actually not even the brain injury. And the headaches can become really difficult. So like occipital neuralgia, if you Google a picture of the occipital nerve, it goes, from the neck all the way kind of along, around the head. So if you have a one-sided headache and you touch it and it's nervy and it's burning and it's kind of a weird type of headache, it might be occipital neuralgia. And in that case, it's not even the brain, it's just a nerve outside of the brain. Cervical spine issues can lead to headache symptoms, which are not the brain injury. Mood disorders, psychiatric disorders, or somatic symptoms can be outside the brain injury. It also can be associated with brain injury too, though. If a kid had migraines before, they can kind of worsen. Tension headaches is not a brain injury. It's outside of there. And then sometimes I get the kids that gets a viral illness right after their concussion. Their symptoms get worse, but it's actually that they had ear infection or something along those lines. Okay, so with more prolonged concussions, usually past 4 weeks, I do categories a little bit because it's a little bit how I treat, but I'm going to kind of go through the categories of different things that I treat. So first would be pain symptoms. So headache, like I said earlier, they can be super complex. There's a lot of different types of headaches. It's not always a concussion. And honestly, I would say, this is just from my experience. This is not statistical or anything, but the most common prolonged headache I get is occipital neuralgia. I'll get kids that are like, I had one that was like out of school for 3 months because of his headache, and actually was his occipital nerve. And it's really painful. I've had these headaches before, and it can be super painful where you can't do anything. But now that kids miss 3 months of school because he's pretty much misdiagnosed with this being prolonged concussion symptoms when we can do other things for it. You know, some of these treatments, you know, you can do medications. There's Botox treatments for, like, if they've had headaches for a long time. For the occipital nerves, we do injections around the occipital nerve that can give significant release. So it all really depends on the cause and how I treat it. Cervical spine problems is a huge complicator of headaches. You know, the muscle tension creates tension headaches and sometimes occipital neuralgia. So, you know, once again, if we attack the cervical spine early, then we can kind of prevent this prolonging symptoms. Cervical spine pain and stiffness is not a reason to hold out for sport, as long as anatomy of the spine is okay. So there are kids that I've sent back that still technically have headaches, but it's not a concussion type headache, it's something different. So there's not always completely asymptomatic when they go back, but they are from the concussion, and that's what really matters. So yeah, cervical spine treatment, physical therapy usually. If indicated, we'll get some imaging. Sometimes they get injections into their neck, and then occasionally a neurosurgery referral, but not too often. All right, I'm going to spend a little bit more time on the, yeah, I saw that. A little bit more time on the vestibular system. I was asking several of my athletic trainer friends about what to focus on, and this is what they told me to focus on, because there's a lot new literature in it and it's pretty complex. So it's a super complex system, and it's been the focus of a lot of research lately because they found that vestibular symptoms actually, you know, if they have vestibular symptoms early, then it correlates with actually increased recovery time. So it's gotten a lot more research on treatment and different things. So for the case of the athletic trainer, actually learning some basic vestibular exercises for athletes can be super helpful if you feel comfortable and you want to treat them a little bit early. This picture is a very simplified version of the vestibular system, but you can see it even in the super simplified picture. It's super complex. You know, your eyeballs are up at the top, and they have muscles attached to them, and those muscles, you know, move your eyes, and there's a lot of input to different areas of the body because it also maintains your balance. Your head moves and your eyes decide whether to move with your head or to look at something else. And then you've got your inner ear, which also controls balance. So, and it's all kind of inputting to different systems. So, you know, no wonder it gets messed up in a concussion. You know, most concussions have, I mean, a lot of them have some type of vestibular problem. So testing the vestibular system, balance testing, and like I said earlier, it's really important to know your athlete. If you're using the SCAT5 methods on a gymnast, they may seem falsely okay because they have amazing balance at baseline. The SCAT6 is better. You just might need to do more challenging assessment for different athletes. And then some athletes have awful balance, and then we just keep it simple for them. But baseline testing is pretty important. I don't know, hopefully you can at least just see this picture. You don't need to really see the words, but this is a nice figure that has all of the a lot of the different exams that we do for vestibular stuff. So the top one, we'll kind of go over a little bit, it's called smooth pursuit. So your head stays still, and usually it's an examiner's finger. You know, you move the finger left to right, and your eyes follow it with your head staying still. If you want to do it horizontally and vertically, if the athlete struggles with this test and symptoms are reproduced, a lot of times it correlates with having trouble tracking things. So like tracking a ball. So maybe don't let them play catch if, even if it's light intensity, if they're having trouble with smooth pursuit. The one under that is saccades. So basically there's two objects, usually fingers. In the eye, the head stays straight, but the eyes quickly jump from one finger to the other. Dysfunction in this area horizontally can be associated with trouble reading. And then vertically, a lot of times you'll see problems with in the classroom and looking up from the board and back down to the paper and note taking and things like that. Near point conversion. So you take an object and you move it closer and closer to the face between their eyes, and you measure when the object doubles or becomes blurry. And if it's more than 6 to 10 centimeters away, that test is abnormal. So dysfunction in that area can correlate with trouble focusing, eye fatigue, things like that. Then you've got visual motor sensitivity, or VMS. The patient holds out their own thumb in front of them. Then they move their whole head, their whole body, and their whole torso horizontally while maintaining focus on the thumb. So that's one of the tests. And then the last test down there is vestibular ocular reflex, or gaze stability. So unlike smooth pursuit and saccades, this is actually an involuntary reflex. So you have a stationary object in front of the patient and have the patient move their head back and forth horizontally and then vertically and staring at the object. And so if they struggle with horizontal, they might have trouble with motion sickness in a car or a really busy hall. And then vertically, they might have trouble running because with their head bobbing up and down and maintaining that eye movement, they can be a struggle with that. All right, so treatment. Like I said, treat early if you're comfortable. It'd be really good to get some exercises if you know a vestibular therapist or somebody to kind of give you some exercises to do with your athletes to treat early. So this will make them often feel awful when you're doing these exercises with them. So I wouldn't do it before school or before anything, maybe in the afternoon, evening. But as soon as those symptoms really build, let them go. You don't want them like thrown up in the trash can. The other thing, so if I see them and these symptoms are lasting, then I'll usually either do more advanced home exercises. There are vestibular therapists out there. There are physical therapists that do vestibular therapy, so I can send there. And then sometimes cervical misalignment, and this is actually pretty common, can cause vestibular dysfunction. So if the top 2 vertebrae are kind of off, like off kilter a little bit, then it can cause a lot of vestibular dysfunction. So sometimes I'll send them to, I know a couple of chiropractors that I very much so trust, and I can send them there. So, once again, the vestibular thing can be a neck problem as well. All right, cognitive dysfunction. So for the high functioning student athlete, this can be super frustrating. All of those symptoms above. Like I said, I do neurocognitive testing in office. I wouldn't expect a primary care physician to have that type of stuff because they don't see this a lot. But with neurocognitive testing, a lot of schools, if you work at a school, are doing baselines, and baselines are super helpful. I have a lot of kids and I'm not sure whether to clear back or not because they're scoring lows in areas in my neurocognitive testing. And then if there's a baseline showing those areas prior to the concussion, it's super helpful for me to get them back quicker. And you can get the student moving along by offering cognitive exercises. There's some just different things that I tell them to do occasionally. And then mood symptoms. So this can be absolutely huge in the athlete. Just keep in mind that the PTSD, the trauma behind the athlete injury. So when you get rocked in the head so hard that it causes a brain injury, it can be really traumatic for anybody. And even like an ACL tear can cause PTSD in the young athlete too. So many kids are super deep down afraid to go back to sport, and they do have an element of PTSD with their head injury. So I really encourage you to be patient and sensitive with these athletes, and remember that at all levels it's their choice of whether they want to return to play or not. There's so many different things that we do for for psychological mood problems in athletes after concussion, and even just in general. So I'm not going to dive into that, but just don't please don't brush this off. Like with all of us in sports medicine and, athletic training and sports in general, it's kind of almost like a military mentality of, oh, brush it off, like you're anxious, brush it off, you're depressed, brush it off, but don't do that. A, it could be a sign that they're not well, their head injury is not well, but B, just for their overall mental health, just, remember that it is super important. Pre-existing psychological disorders can heavily complicate the concussion picture. And then sometimes I do formal neuropsychological testing to kind of help differentiate that and help us see if we're ready, if we're ready for, return to play or different treatments and things like that. So I'll kind of keep this brief. I could go on, I could go on with mood stuff for forever because it is a lot of what I see in the concussion center, but I'll just kind of keep that simple. All right, still not question time at the end. We're almost done. All right, so final clearance. Basically, I need them to A, have a normal exam. I didn't put that on there, but be symptomatic or asymptomatic, off all meds related to the concussion, and then able to tolerate exercise through the return to play protocol. And then they need to be back to school without accommodations. I've had a couple try to slip in where they're still getting like extra time for tests, and it's like, no, if you're getting extra time for tests, then you're obviously not well, unless you needed it before. And then just real briefly, the return to play protocol. Now we're back at your guys' expertise. I just sign off on it. I don't see this. So this is the AT18 form we use for Florida in high schools. And it has this little return to play protocol down at the bottom of it that we sign off on before clearance to play. And this is a legal document. I don't know if everybody here is from Florida or where anybody's from, but this is a nice little general return to play protocol. There's a lot of variations of exactly what to do and what exact exercises to do. But this is a decent template because it's just kind of graded exercise. You get more and more intense as you go along, and then, full contact practice and then return to play. All right, so back to the field. So return to play protocol. What do you do if there are symptoms provoked by return to play protocol? That's usually a time to come back and see a sports doctor because something's going on. And so, we've got the athletes that don't, they want to play because they love sports. Many of us were athletes in our time, and probably a good portion of us were a little bit fibbers ourselves trying to get back to sport. Some things to look out for. So if you're in the school working, you can do this. So if they're struggling in school, their grades are dropping and complete homework, low test scores than usual, the teachers are still giving them accommodations, that's a sign they're not well. If they're pushing through symptoms, so you see them on the field, they're not playing well as usual, they've got some visual symptoms, the sun's bothering them, they need more frequent breaks, though if they've been out a while, they also could be out of shape a little bit. They're antisocial, they're not hanging out with their friends, there's parental concerns, they're not themselves at home, or if they just seem off to you with their mood or their personality. Those are all things to really look out for in our athletes. We have we call them minimizers, the athletes that love to play and they want to play, and then they minimize their symptoms. And, I warn them all over the place. I warn them, of the dangers of going back to play when they're not completely well, but they're kids a lot of times, and they're gonna do what they want to do a lot. So those are some things you can kind of look out for them. All right, so retiring from sport, this is the last little thing that we'll talk about. Very incomplete evidence. There's no set protocol, but I will say it needs to be a conversation with multiple people, especially a physician. In your career, I'm sure you'll be asked, that I get asked all the time, especially if you work with kids by their parents. They get asked on a weekly basis, should my kid still play sport? He's had one concussion. And it's like, yeah. So basically, personally what I do is I start this discussion once that number gets higher, and if the symptoms start getting more prolonged, and or less intense injury starts causing intense symptoms. So I think I had one that had a lot of concussions, and then she just barely tapped her head on a fence trying to catch a fly ball. And and then she had a cascade of symptoms just from a mild impact. And at that point, it's like, okay, no, we need to protect this person as a person, and not protect them a little bit from themselves, protect their brains a little bit. So yeah, basically, make sure it's a conversation with the patient, with family, with you, with physician, and then, make a solid decision. All right, those are some of all the sources that I used for this presentation. And now I'm ready for comments. We got about 10 minutes. I gotta see how I read the comments.
Yeah, so what'll happen is they'll post questions into the question box, and then I can just feed those over to you.
Cool.
The first one comes from Rachel. She's asking for your, if you had any specific examples when you were talking about light activity for that days 2 to 10 that they can be able to participate in.
Yeah, definitely. So usually I tell them to start with taking a nice walk, and then I tell them this isn't like a speed walk, like an athletic walk. This is like a geriatric walk. You're walking like, slow. And then, if we're not doing the heart rate thing, then I'll just kind of have them progress as they feel well. That it can be super variable. Some of them are even uncomfortable taking a walk. So, okay. And I say, if you're uncomfortable, just stop, try it again the next day, and then, keep doing it like that, and kind of increase the activity. I really like, I like walking, cycling, jogging, because they're very easy. They're low risk of them hitting their heads again, and they're pretty easy to measure. Someone can say, yeah, I walked really slow for 20 minutes that first day, and then I walked at this pace for this long. So it's pretty easy to kind of measure for them. But yeah, I usually just stick to real simple. And with athletes returning to sport or being concussed and wanting to do sport related activities, also keep in mind that when they're concussed, they're at higher risk for musculoskeletal injury because their proprioception is usually off. So that's the time that you might see them get ankle sprains and things along those lines. So you really want to do activities that are lower risk for that. Did that answer that?
Yes. All right. The next question comes from Ronald, and he asks, are you using any neuropsychological testing methods, impact, sway, concussion vital signs with your return to play decisions?
Yes, I do. I wasn't gonna mention them, the specific brands or anything like that, but yes, I do use formal neurocognitive testing.
And the next question comes from Ashley, and she asks, after the first 30 days, do you continue to do that same neurocognitive testing, or does it become more focused on what their persistent symptoms are, or both?
Yeah, so I kind of leave that on depending on how they're doing. If their symptoms are neurocognitively based, then I'll keep testing them after that time period. But if they've tested normal neurocognitively and it's just like a headache or something along those lines, and their neurocognitive testing is back to baseline, I don't make them take it again.
The next question comes from Donald. Can a concussion cause neck pain as a symptom acutely? MDs beat me up when I withhold athletes during games. Okay, yeah, there we go. The doctors apparently get upset when he withholds athletes from games.
Say that again, sorry.
Yeah, so I'm okay. And maybe Donald, if you want to re-ask that, just so I can reflect your question appropriately. Can a concussion cause neck pain as a symptom acutely?
Okay.
And I guess the issue he has had is that he will withhold athletes during games, and so he gets some type of pushback, and I'm not sure if it's from the doctors or maybe from the coaches.
Okay. So the concussion itself won't cause neck pain. The neck pain is a separate injury from the concussion, but there's definitely reason to hold an athlete out if they have neck pain and more worrisome symptoms. It also depends on what level you're the athletic trainer at. You know, if it's I hate to treat you differently, but if it's younger and the stakes are low and everything, and you really just want to be on the safest side. But if they're professional, then okay, you really want to weigh out whether the neck injury is severe or not. But overall, no, a concussion should not cause a neck injury, but they're almost always come together because any concussion, your neck is going to be involved. So if they have a neck injury, there's a high suspicion for a concussion. They're just separate. That makes sense.
All right. Zachary asks, do you recommend any additional clearance office visits for a return to contact sport, or do you do one visit for full clearance after monitored contact?
So usually what I do is, so when they get the concussion, I'll see them, and then I'll see them again, and you know, I'll basically see them throughout the concussion. Sometimes it's one more time, sometimes it's several times, depending on the length of time and you know what they're doing. But I'll see them one more time when they're asymptomatic to clear them to do return to play protocol. And then after they do the protocol, I don't see them again unless they struggle with it.
And Donald did respond that he felt that the question was addressed appropriate, or like was reflected appropriately, and then certainly answered.
Okay, cool.
Yeah. We might give them another minute or two, but I certainly love the way that you put the, you know, SCAT5 juxtaposed to the SCAT6 so that everyone could kind of see specifically what those differences are. I thought that was a really great way to do it.
Oh, thank you.
All right. Well,
that's it.
I would say so. Yeah, we've given them that minute, so hopefully they got all of their burning questions answered. Thank you so much for putting this presentation together. I know it was a big ask because we had asked you probably 6 months ago, and then you know a month before you're about to give a talk, the biggest changes happen, and you kind of have to go back and revamp the whole presentation. So I know that was a bit more work than you had anticipated.
No, it's always good for me to go over that stuff too.
Yeah, awesome. And thank you everyone for joining us tonight. I hope everyone has a great week, and then we'll see you again next month.
Great. Thank you guys.
Okay.